Yes, thank you so much for the introduction. Today I'll talk about something called PPG, pressure pullback gradient, which is a new physiological index that is now available to you to help you optimize the PCI results. As you will see in my talk tomorrow, I'll talk about the different physiology parameters and indices that are out there that will help you optimize your PCI results and help actually improve the outcome for your patient by reducing the risk of future cardiovascular events. But today I'll focus about PPG. As you all know, angiography is not enough by itself to identify diffuse versus focal lesions. There is so much subjectivity from one operator to the other to judge if it is focal or if it is diffuse. 1 in 4 patients, despite angiographically good PCI, they will continue to have angina 1 year later. And the lower the PCI, the FFR at the end of the PCI, is the higher the risk of ongoing angina down the road and the higher risk of major adverse cardiovascular events. And all the studies show that if the lesion is already diffuse, PCI does not work as good as other interventions that sometimes include surgery. So it is very important to try to identify which lesion is more focal versus which is more diffuse. So it helps you make the decision regarding do you do PCI or not for that lesion. So for the PPG, the pressure pullback gradient, essentially it is a gradient from 0 to 1. I'll show you how the software does the calculation, but the higher the number, the closer it is to 1, is the more focal is the lesion. The lower the number is, the closer to 0, the more diffuse the lesion is. So keep that in your mind as you analyze this, as I show you the cases in a few minutes. So what is important about PPG is that they actually looked at the PPG done for cases and looked at what was the final FFR once they did PCI. And they found that it actually can help you predict what will be the final FFR when you do PCI. And when they looked also at the major adverse cardiovascular events and angina and so on, they found that you can actually predict if the patient will do well afterwards and if the angina will go away with PCI. And as you can see here, the cutoff was around 0.62. So a higher value, higher than 0.62, indicated a focal lesion, indicated that the patient will do well with PCI. Lower than that indicated diffuse lesion and that the patient will not do well with PCI in that setting. Same applied for peri-procedural MI. They found that the more focal the lesion is, the better the outcome, the less the risk of angina down the road. And this is the formula by which the software does the analysis and the calculation for you. I'll show you a few cases just to put this into perspective. 2 patients of mine. The first one, 69-year-old male patient with exertional chest pain, with the past medical history of diabetes, dyslipidemia, CKD, and PPH, with normal ejection fraction, with no significant valvular disease. This is the angiogram. The RCA has diffuse disease. The PDA is small with severe lesion there. The circumflex coronary artery has severe lesion proximally. Same applies for the diagonal. And when you look at the LAD angiographically, like proximally, you appreciate the tightest spot. But in this case, I wanted to kind of see what will be a good solution for this patient long term. So I did, in his case, the PPG pullback. Essentially, what it does, it gives you what is the FFR, and also at the same time, it gives you the PPG result. So in this case, the LAD, we expected it will be abnormal, ischemic. The FFR was 0.78. But when you look at the pressure pullback gradient, the gradient came back very low at 0.36. Remember, I said from 0 to 1, the lower the number is, the more diffuse the lesion. So this is a very diffuse lesion. And when you look at the curve actually of the FFR, you can see it is kind of very linear, indicating that this is a very diffuse lesion, and hence we felt PCI will not be a good option in this case, especially also knowing about the other coronary artery disease that he has, and hence we referred him for surgery, and he did very well with that. The other example is the second case, 83-year-old male with exertional chest pain, with the past medical history of type 2 diabetes mellitus, dyslipidemia, hypertension, COPD, normal ejection fraction, no significant valvular disease. And this is the cath. If you look at the RCA here, angiographically, the thing that catches the eye is the lesion in the mid to distal RCA, but not really much in the proximal part of the RCA. The left main injection, there was damping in pressure indicating some lesion at the ostium of the left main, but in the proximal to mid LAD, there was another severe lesion. In his case, we actually thought about surgery, referred him for surgery, but he was turned down for surgery and advanced for PCI. So the first step we did is we did PCI left main to the LAD, looked good. We left the distal LAD disease for medical therapy. And then I guess this is where the point about PPG comes into play. If you remember how the RCA looked, I mentioned the lesion is more distal, angiographically at least, but we wanted to kind of predict what will be the final FFR once we do PCI. So that's why we did the FFR PPG pullback. FFR was abnormal at 0.77. But what caught our attention is, beside the fact that the PPG was very low at 0.51, indicating this is a very diffuse disease, but when we did our analysis, we realized that if we only stent that mid to distal lesion, at the end of the case, the FFR will be still very abnormal, and this patient will not do as well, and most likely will continue to have angina down the road, and as I showed with the data, will have a higher chance of major adverse cardiovascular events down the road. So then the nice thing about this software is you can put your marker as you do the pullback at the different spots, and in this case, as you can see with the pullback, we chose the one distal to the lesion here, and then we realized that it will not get back to close to normal up to when you reach the proximal part of the RCA. And this software, once you move these markers, the white markers to the right and to the left, it will actually give you what expected delta FFR you will get. So if the FFR was here 0.77, how much it will be here when you reach to that level, when you do PCI from this point to that PCI. And also it will tell you in percentage wise how much you expect improvement in the FFR if you do PCI from point A to point B. So in a way, it really helped us in this case actually plan our PCI, and we ended up stenting from longer than we would have done with angiography alone, and we had a good result at the end. So in the first case, you saw how it helped us predict that this patient will not do well with PCI. We went with surgery. In this case, it helped us identify from where to stent to get the ideal FFR. As you all know, at the end of the procedure, after you finish a PCI, if the FFR is not great, if not more than 0.88, then most likely this patient will continue to have angina, and this patient will have higher risk of future adverse cardiovascular events. So how to perform, just I'll spend 2 minutes quickly going over this. It's super easy, especially for the ones who use FFR day in, day out. So essentially, after you finish doing the FFR, while you are doing the hyperemia with the intravenous adenosine, essentially you click on the PPG pullback here. It will quickly ask you quick questions, identify the vessel, and you will start your pullback. And the key here is you have to do a very slow pullback over 20 to 30 seconds, starting from distal to the lesion all the way back to the guide. And then once you click stop, it will give you the number. And this is how the screen will look like. The PPG will be on this side of the screen. As I mentioned, the lower it is, the more diffuse the lesion is. The higher it is, more than 0.62, it indicates a focal lesion. You'll get your FFR as normal. And once you move these markers, you can then do your analysis of what will be the FFR if you only stent from point A to point B, and this way it can help you optimize your PCI in that case. So in summary, it is another newer physiological index that is available now for our use, in addition to all the other indices we use in our practice. It will help you predict which lesion will do better with PCI versus not doing PCI. The more the focal the lesion is, the higher the PPG number will be closer to 1, which will indicate a higher chance of post-PCI FFR being higher, and symptoms relief at 1 year, 2 years down the road, and lower chance of peri-procedural myocardial injury. On the other hand, if it is diffuse, the PPG will be much lower, and you would expect the post-PCI FFR to be low with higher peri-procedural cardiovascular events risk in general. With that, I conclude. Thank you so much.